So I'd like to introduce Dr. Akagami to the Vancouver Acromegaly Support Group, and thank you for taking the time from your busy schedule to come and do a presentation for us all. Dr. Akagami is the Program Director and Clinical Associate Professor in the Division of Neurosurgery at the Vancouver General Hospital. Dr. Akagami was born in Osaka, Japan, and obtained a degree in biochemistry from UBC and the medical degree from the University of Toronto. He was a rotating intern at the Greater Victoria Hospital Society and has a general medical license. Following internship, Dr. Akagami's neurosurgical residency was done in Vancouver at the University of British Columbia, and then became a fellow of the Royal College of Surgeons in Canada in 2000. Dr. Akagami then spent a year as a clinical fellow in skull base and vascular microneurosurgery under the guidance of Dr. Legam Sekar in Washington, D.C., Virginia, which he then returned back to Vancouver and has been practicing neurosurgeon and specializing in skull-based tumors. Dr. Akagami also holds a Master's of Health Sciences graduate degree in clinical epidemiology and biostatistics, which was obtained from the University of British Columbia. Dr. Akagami is also involved with the Skull-Based Surgery Committee and has been a director or instructor in local, national, and international skull-based courses. Dr. Akagami is a highly recognized and acknowledged expert in the field of skull-based surgery. He has performed over 530 pituitary tumors and 400 acoustic neuroroma surgeries. Dr. Akagami has many more acknowledgments and recognitions with his career and is involved with clinical research and current projects, which you may find on the Division of Neurosurgery website. Welcome, Dr. Akagami.
Thank you very much, Deanna, for that nice introduction, and good for you and the other members of the committee for starting this and helping yourselves and supporting yourselves. So I'm very happy to be here. So I've been asked to talk about, this is the title that was given me, so I'll try my best to go over some of these things. And I'll try to give you an overview of the treatments of acromegaly, and I'll go over some of the surgery aspects that I really don't have time to go through in detail in the office. So some of the more intricate sort of problems we have, and it's not it's not as simple as what you see in websites and YouTube videos and things. There's lots of sort of fine minutia, and there's multiple different procedures that can be done for these tumors as well. So I'll try to clarify some of that for you. Okay. I think we'll have lots of time, so you can sort of put your hand up and ask questions if there's something that you don't understand or you have questions about. I do have some pictures and videos, but I think I think they're okay seeing what kind of videos are on YouTube. I don't think it should be too upsetting or anything like that, I hope.
Before I had my surgery, I went on YouTube.
Did you? Yeah, was that okay? Okay, good. Anyway, so acromegaly surgery 101. So what is acromegaly? Well, you guys all know this, right? But I can go through some of it. It's a functioning pituitary tumor, meaning that it's a pituitary tumor in the pituitary gland, but it's actually producing extra hormone. The vast majority of these tumors, well, maybe not the vast majority, but 50% of these tumors actually don't produce an extra hormone, and patients present because of the pressure from the growth of the tumor affecting the vision nerves and other structures around the pituitary fossa and pituitary gland. But in patients where the tumors actually produce a hormone, like acromegaly, most of the time patients present with the symptoms associated with the increase in hormone. The other tumors that are functioning are tumors that produce cortisol, so Cushing's disease. There's a rare one called that produces thyroid stimulating hormone as well. There's one that's called a prolactinoma, which causes female breast milk promoting type of hormone. Well, anyways, and that particular tumor actually is really interesting because that can be, like acromegaly, can be sometimes be suppressed or controlled with a pill. So produces growth hormone, elevated levels of growth hormone. You guys know this too. It's insidious onset because the changes take a long time to occur and things happen gradually. Patients and often physicians don't notice the gradual change. And it's often, a family member who hasn't seen somebody for a number of years that notices that there's a significant change in the person's appearance, or a new physician that is doing a locum or something like that notices a particular feature that the regular physician, your family doctor, your regular family doctor may have not have noticed because of the sort of gradual changes. Because of that, it's often a delayed diagnosis. And we know because of the complications associated with acromegaly that they can shorten your life without treatment. So the features, right? I guess I don't really need to go over all these. But coarse facial features, you can have bony growth so that your jaw can be more protuberant. Some patients describe having an overbite that disappears and becomes an underbite. Increased space between the teeth, so you maybe have to floss a little bit easier, I guess. Large tongue, snoring, or sleep apnea. Skin tags, broad fingers, having to resize your rings. Large feet, so shoe size increase. More sweating. Arthritis. Other hormones get affected, right? So you can have impotence or amenorrhea, carpal tunnel syndrome, diabetes, hypertension, heart problems, cardiomyopathies, intestinal problems, intestinal growths, polyps, and sometimes intestinal cancers. And in general, because growth hormone causes increase or promotes growth, it can put you at risk for other tumors and cancers. So diagnosis, well, your growth hormones increased, and that can be measured. But sometimes the growth hormone can vary quite a bit. So it's better to do what's called an IGF-1. It's a insulin-like growth factor 1. It's produced by the liver in response to the growth hormone. And IGF-1 usually has a more constant level that can be measured easier. There's something called oral glucose tolerance test, where you drink something that's really sweet and measure your growth hormone. Growth hormone is a stress hormone. So when your body's under stress, the growth hormone increases. I guess if your glucose is low, then your body's under stress and your growth hormone's high. But if you drink something that has lots of glucose and your glucose is high, normally your growth hormone should decrease. But in patients with acromegaly, the growth hormone does not decrease. MRI scan often shows a little lump on the pituitary gland. In terms of management, for other tumors that aren't producing a hormone, if it's a non-functioning tumor, sometimes we just follow things on scans. But in patients with acromegaly with the growth hormones high, just observation is not appropriate and in general needs treatment. With respect to treatment, there's medical suppression, radiation, and surgery. And I'll go over them in more detail. So medical suppression. So there's a few different medications that can do this. There's one that suppresses the production of growth hormone. So there's somatostatin analogs. There's octreotide, larinotide, pasirotide, I guess. And sometimes these can slowly shrink the tumors as well. There's a medication that decreases the effectiveness of growth hormone, pegvisomat. Often doesn't affect the tumor size, but it's very effective in reducing the effect of growth hormone on the different organs. There's other hormones that suppress the pituitary gland in general, like bromocriptine and cabergoline. They tend not to work as well as the other medications, but can help in certain situations to decrease your growth hormone as well. The problems with the medical suppression is that sometimes it's not always effective. You end up requiring really for lifelong treatment. They're injections and they can be expensive. There are some side effects: slow heart rate, nausea, vomiting, diarrhea, stomach pain, dizziness, headache, liver problems, and pain at the site of injection. Often it's used in conjunction with other treatments, so sometimes while waiting for surgery, sometimes in conjunction with surgery if the surgery itself isn't 100% effective. Sometimes it's used while waiting for the radiation to take effect. Radiation treatments. The radiation treatments we use for these tumors in general is what's called focused or conformational. And basically it uses different type of technologies to focus the radiation onto the tumor. And that can be done by various multiple small beams of radiation that can focus onto the tumor. Sometimes we use arcs of radiation that can go over and cross over where the tumor is, so that the dose of radiation increases at where the tumor is, but is low everywhere else. You can actually change the shape of the beam of the radiation to reflect the shape of the tumor better as well. And in general, it does work. It stops tumors from growing. It does decrease the growth hormone, but often it takes many years. Sometimes it takes a year or even 2 years for the hormone to actually start to decrease. And while waiting for that, sometimes the medical suppression is very useful. The other problem, though, is that sometimes the other pituitary hormones, probably about half the patients, the other hormones that seem to be working okay before the radiation can get affected, so you end up requiring replacement pills to replace the parts, the hormones that were being produced by the normal pituitary gland. There are some risks to surrounding nerves and blood vessels. So if your tumor is large and it's pushing on your vision nerve and there's no space between the vision nerve and the tumor, we know that the radiation, even if it's very accurate and accurate within a millimeter or two, if your tumor is right in contact with the vision nerve, then there's a chance that the vision nerve itself can be injured as well. And unfortunately, the vision nerve tends to be one of the more sensitive nerves to the radiation. There's vessels around the tumor as well. Rarely, the radiation cause some injury to the vessels, cause strokes. Quite rare, though. And there's also a very small risk of secondary malignancy. So we do know that radiation can sometimes cause cancer. Doesn't happen very often, and it's something that happens many years down the road. It's something we worry more about in younger patients who have longer to live. And we do think the risks are fairly small. I think 1 in 1,000 is probably an overestimate. It's probably less than that, but it is something that comes into the equation. So radiation in general isn't a first-line treatment. Sometimes we rely on it if the anatomy is not appropriate for surgery, where certain structures are in the way, which I'll show you a little bit later, or you have surgery and we can't get all the tumor out and you're on the suppression medications, but the suppression medications aren't working. Then sometimes we go and consider doing radiation treatments. Okay. So surgery. I'm going through this pretty quickly. You have any questions? No? Yeah. Yeah. So there's a bunch of brand names of machines that do the radiation. So there's a Gamma knife machine, Saber knife machine, Novalis, there's a Linex. There's a whole bunch of brand names of machines. But really, The technology in the machines are a little bit different, but the concept is the same. So multiple beams of radiation that sort of cone in and focus down onto the tumor so that you get a high dose of radiation at the tumor and very low dose to the surrounding tissue. Gamma knife machine in general can only do one big dose of radiation, which probably isn't the best thing if your tumor is very close to the vision nerve. So the problem with using the gamma knife for pituitary tumors is that sometimes you have to underdose the top of the tumor to avoid the radiation to the vision nerve. Okay, whereas some of the other machines can give multiple small doses of radiation. So the other machines can give smaller doses, which we think normal tissue has a chance to recover between radiation doses, and whereas tumor tissue doesn't recover. So that we can give still a high dose to the top of the tumor, close to the vision nerve, but your vision nerve is still okay. But it's a totally different type of sort of the way it's given, because it's one treatment a day, 5 times a week for a month or sometimes a little bit longer, versus one big treatment with radiation with a gamma knife. Okay, go on to surgery. Okay, so there's a few different ways that we can get to the pituitary gland, and I'll try to show you on the skull where things are and try to go over this. And really, it really depends on what other structures are involved and whether it's a recurrence or it depends on anatomy, which surgical approach we choose, and also depends on the surgeon's sort of experience as well. And I'll go over that some too. So you can do a craniotomy, which is an operation from above, where we make an incision on your scalp, and we turn some of the skin down, make a little window in the bone to get the tumor out from above. We can do a transfemoral procedure, where it's an operation where you do through the nostril, and so you don't have an incision on your scalp, which is a good thing, I think. But there are multiple variations of the transfemoral surgery. So you do the transfemoral surgery using a microscope, or you can use it during the endoscope, like we've been doing recently. But I'll go over the pros and cons in detail in a little bit. So this is my plastic skull. The patients who have been at my office would probably recognize these. All right, so this one here, the top's been taken off, right? So you're looking down from above. It's hard to see, but the eye socket's underneath here. So we're looking, this is a picture from the side. Let's see, here, do you see that better? So this is a picture from the side, right? So that's the jawbone there, right? And this is the ear canal. This is the eye socket, that's the nose. So this skull, the top's been taken off, so you can look from above. So we're looking from above here, so your eye socket's underneath there, right? And this is the jaw, or the jaw, this part here, right? The cheekbone, sorry, the cheekbone. Well, anyways, so the area we're interested in is in this area right here. These two holes are where the vision nerves come out. The vision nerves come out and they go directly towards your brain from here. There's a little depression in the bone here, and that's called the sella, and that's where the pituitary gland sits. And this sella here, from the side, you can see it's sort of saddle shaped like that, right? Your vision nerves would come out from about there. And the hole for the vision nerve is there, which corresponds to that. Okay, so normally, as I said, the vision nerves come out and go directly towards your brain from front to back. But if there's a tumor in this area, it can get big enough to start pushing up on the vision nerve, and that's one of the problems. Okay, so this is a specimen. Just ignore this endoscope for now, but this is a slice right down the middle again, okay? And this is the tongue, it's the nasal cavity, okay? And this bone here, and this is an opening called sphenoid air sinus. That's an air cavity that most patients have, not always, most patients have. And this here, right here, is the sella. So this corresponds to this right here, okay? And this just sort of shows that it's a really straight shot through your nostril, right? There's a layer of bone you have to get through here to get into the sphenoid air sinus, and then there's some bone here to get into the pituitary gland where your pituitary tumor is. And this is your vision nerve up there. If you look in through your nose, these are the structures you would see. So this here, this cavity, this is what you would see if you were looking through the scope and looking up towards that. So if you're looking directly that way, this is what you would see, or you would see most of the time. The anatomy is variable, but you should see a bulge from the blood vessels, the carotid arteries, on both sides. This is where the pituitary gland sits. On the other side, it's bone. There's a layer of bone here, and this is called the bone of the sella. The other side is where the pituitary gland sits. The vision nerves are on top, and there's a layer of bone around here as well. But this is normally what you would see. I can go back a few slides there. So if you go back to this slide here, the blood vessel, right, comes out of those two holes. So the carotid artery comes out through those two holes and wraps beside the pituitary gland. And those blood vessels, right, are these there. And there's a thin layer of bone over top. Okay, so very important structures nearby. If you see this, then you can see these bulges. You can see the bulge from the optic nerve, and you're sort of comfortable knowing where the cell is and where the tumor should be on the other side. But sometimes the anatomy isn't easy to work out, and sometimes things can look like this. And if you stare at it, you might be able to figure out that the blood vessels on this side and the blood vessels probably here as well. But all of this is probably the nerve on top. And the bulge from the cella, right, isn't very obvious. It's in here somewhere. And there's some bridges of bone that sort of obscures things. Hopefully your surgeons sort of studied the scans really well, so they know what the anatomy looks like. But sometimes it's a little bit not always predictable what things will look like once you look inside. These bony structures are very important for you to sort of, for the surgeon to sort of identify in the scans preoperatively. And one of the reasons I do a CT scan right before the operation is that I can see these little fine pieces of bone really quite well on a CT scan that you can't see on an MRI scan. And if I can see these bones, right, I can tell from looking at the pictures on the CT scan, where I am with relationship to those other structures. And that's one of the things I use during surgery. So this is a more straightforward pituitary tumor. So this is a slice up and down through the pituitary gland, right? So the vision nerve actually comes out as two, but comes together in the middle. And this is just where the tumor or the vision nerve has come together in the middle. And underneath that, there's something called the pituitary stalk, and that's the structure that connects the pituitary gland to the brain. And that's the structure that allows the brain to control the pituitary gland. And the cellular structures are here. On this picture, this part, this sort of crescent-shaped part is probably the normal pituitary gland, and this is the actual tumor. Okay, and normally the top of the pituitary gland is concave, like this. It's concave, but you can see on this patient it's convex because the tumor is pushing things up a little bit. You can imagine if this got big enough, it'll start pushing up against the vision nerves. The important structures close by, that black dot there and there, those are the carotid arteries, right? Those are the structures. That's what you could see on this scan, right? These things there. And it's a little bit hard to see, but this gray structure there, those are the nerves that move your eye up and down and to the side, opens and closes your eyelids, and also opens your eyelids, sorry, and also changes the size of your pupil, right? And there's nerves here for sensation for the forehead and cheek, and there's another nerve here, as part of this one there, that moves your eye to the side as well. So all those structures are very close by. This is an MRI scan. And although it shows the soft tissue really well, as I said, it doesn't show the bone very well. If I stare at this, there is a piece of bone here, right? A very thin piece of bone, but you can't see it very well on the MRI. On the CT scan, you'd be able to see that clearly. Okay. So when do we do a craniotomy? Sometimes we have to do a craniotomy in tumors that have a lot of lateral extension. So if it's a big tumor that sort of goes over to the side, You can imagine, let's see. So if a tumor, actually I think I have a picture. If a tumor goes all the way over to the side, right? Then if you can imagine coming in through the nose, between the arteries, it's actually really quite difficult to work above the arteries, to look around the corner. There are endoscopes, there are scopes that sort of you can use to look around the side, but it becomes very difficult to operate when you're looking at a screen that's sort of looking off that way, and your hands are working sort of in a front and back plane, but what you're looking at is looking off to the side, and it's actually quite difficult to do. So for tumors that have a lot of lateral extension, I usually would have to recommend a craniotomy from above. If the blood vessels are encased, depending on the level of encasement, I would recommend an operation from above. I'll try to show you some pictures, but sometimes it becomes very difficult to do fine dissection on blood vessels, and sometimes if there is unfortunately a blood vessel injury, it's very difficult to repair it through the nose. I can repair it if I do an opening from above, but it becomes very difficult to repair it through the nose. Sometimes with recurrent tumors where I know there's going to be a lot of scar tissue, some tumors are very, very firm, very hard, and often not predictable, but sometimes we do an operation through the nose and we just can't, with the instruments we have, we just can't resect the tumor, and sometimes we have to go back in through a craniotomy. The tumors can sometimes be rock hard, and with the instruments and scraping instruments that we have through the nose, it becomes more difficult. If the transfemoral surgery is unsuccessful, for a number of reasons, sometimes we have to resort to a craniotomy. It also depends on the anatomy. So if those carotid arteries, the bulges you saw from the side, sometimes the arteries actually come together in the middle. If it comes together in the middle, there's no space to work between, and sometimes requires a craniotomy. So this one, so this is another slice, exact same sort of slice, right from the up and down. This is the vision nerve again. That's the pituitary stalk. Yeah? Okay. And this is the tumor on this side, okay? And this is the normal pituitary gland on this side. But you can see the arteries, right? They're not sitting over to the side. They're sort of swooping over and coming towards the middle. And the space between here actually is probably less than 5 millimeters. It's only about 3 millimeters or so. My scope is about 4 millimeters. Most of my instruments are probably, even smaller instruments are about 2 millimeters in size. So it becomes very difficult to work through this narrow corridor. In this situation, I might have to recommend a craniotomy. So this is another patient with a very large tumor. Okay, all these patients are acromegalics. This is a very large tumor. So you can imagine, right? I was telling you that this is the picture from the side again. If you go back to that picture where you saw the rod up through the nasal cavity, right? And I told you that the vision nerve was right on top. The vision nerve is supposed to come out through the holes for the vision nerves, right at the base of the skull here. And it's supposed to go directly back towards the brain, right? But you can imagine with this tumor, right? It's going to be draped over top. And this is a picture from the front. So again, this picture is a picture sliced like this. This one here is a picture up and down, like the previous picture with the small tumors I was showing you. You can see how this is the carotid artery, and you can see how much the tumor is sort of draped over top towards the side. And also, this is a branch of this blood vessel, which is completely encased in a tumor. And in this situation, I wouldn't feel comfortable working through the nose to try to remove a lot of this tumor. And it's just, it's a little bit, it's a difference between, working through a nostril and using an instrument that's very long, and they're pistol grip instruments. I didn't bring any pictures of the instruments, but they're pistol grip instruments when we're working through the nose. So it's like a long rod with which actuates grasping thing or scissors, and that you sort of activate with little sort of triggers. The sort of the delicate sort of dissection that needs to be done to peel the tumor off the blood vessels, is more difficult. I can do it, but I don't like doing it through the nose. It's just I don't have as much control. If I do it from above through a regular craniotomy with regular hand micro instruments, I can do a better job. And yeah,
So what percentage of your pituitary adenomas do you take out via craniotomy?
very, very small. So probably percentage-wise, 5% or less, because most of them are smaller. Most of them don't have this anatomy.
Okay, in the cella, what would be the largest type of a tumor? Like, don't give me millimeters, I'm from old school.
Yeah.
Say the size of a
Well,
peanut.
Yeah, well,
Is that
well,
growing out of the cella?
oh yeah, no, it's totally out of the cella. This tumor is totally,
Less
so
than
this,
peanut size?
yeah, so the cella normally is only about a centimeter or half an inch, like 1/3 of an inch. Normally about 1/3 of an inch in size, right? So any tumor bigger than that is going to spill over or go into the structures around it.
So that's about like the size of a pea.
No, it's a little bit bigger than a pea. Yeah,
Okay.
yeah, something like that.
Size of the pituitary.
Yeah.
What it kind of looks like.
Yeah, something like that. But this is 4 or 5 centimeters. This is big. So this is 2 inches. Yeah. 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 Pituitary tumor? Not much bigger than this. I have a few patients with tumors this size, a little bit bigger, something like that. Yeah.
So I'm thinking if you're only doing 5% by craniotomy,
Yeah.
would that be too many surgeons in Canada who actually will really venture that way?
Yes or no? We do craniotomies for other tumors, right? So it's not like a specific thing. Like there's other tumors that look like or can be in this area that we do craniotomies for, and they're not pituitary tumors. Yeah, I mean we do craniotomies for a lot of other tumors.
Have you ever had any tumors grow into the acromegaly?
I haven't. Most of them surround it. Most of the time they don't. Although they surround it, they don't occlude the artery most of the time. Unless there's something special or there's something unusual that happens, it's like previous radiation, because sometimes the radiation can cause some hardening of the blood vessel as well. So if you had a tumor that was encasing the carotid artery, and if you had radiation previously, you may have be a little bit more risk for the blood vessel being constricted or injured by the tumor. Sometimes you can have a situation where the tumor, as tumors grow, sometimes you can have a situation called apoplexy. And apoplexy is either, it's usually a combination of the tumor, some of the tumor dying, having a stroke. So what happens is that the tumor grows, and the blood vessels that try to promote the growth are abnormal as well, and the tumor sort of outstrips the blood supply, so outgrows the blood supply. So the tumor doesn't have very good blood supply, and it dies off, like certain parts of it die off. But what happens is that when parts of the tumor die off, the tumor can swell. If it's a slow growth, if this is, these tumors are big, but if it's growing, only a couple millimeters per year, the brain's able to compensate, right? But if it swells by a couple millimeters over a few hours, patients can have a lot of symptoms and become blind sometimes. When you have strokes or parts of the tumor die, the blood vessels that were feeding that have nowhere to go to, and sometimes the blood vessels leak, right? And then you can have hemorrhage inside the tumor as well. And sometimes just because the swelling and leakage of blood vessel and because of where it is and sort of contained within the bone and some membranes, the pressure within that tumor can increase. And if the carotid artery happens to be inside that, sometimes that can get constricted and you can get strokes. It doesn't happen very often, it's very rare. Yes? So it depends on what your, macroadenomas mean tumors bigger than 1 centimeter, right? So if your tumor's bigger than 1 centimeter and it's nicely shaped, it's shaped like an egg, and something that can be easily, relatively easily accessed, and there's reasonable planes around it, the success rate's pretty good, probably about 70 or 80%, right? If you have a tumor that encases blood vessels or very large and goes over to the side and has different sort of lobules and nooks and crannies, the chance of cure from surgery is probably 0, right? You're gonna need some other things. You're gonna need radiation treatments, and you're gonna need some suppression medications. We still do surgery though, right, to decrease the pressure off the other structures and also hopefully decrease the amount of medication you need as well. So anyway, so I was just saying that, for tumors like this where vessels are encased and stuff, if I injure the blood vessel, I can repair it. If I'm operating from above, I can't repair it very easily from below. So this is another skull. There's different craniotomies as well, right? So if you have a tumor that's mostly in the middle, doesn't go off to one side, you can have an operation down the middle where, so these are the eye sockets. So this is a little bit bigger than we would normally make it, but we'd make an opening in the forehead, right? And I would remove some of the bone around the bridge of the nose and around the eye socket, and basically remove this bone, right, to get access to the tumor, which is in here. And the reason I remove all the bone around the nose and eye socket and whatnot is that I can put the bone back, and the bone heals very well, and I can push the eye socket eyeballs down actually, and eyes are bruised, but they heal perfectly fine. But if I have to lift up on the brain, right, all this is done so that I don't have to lift up on the brain as much. So if I have to lift up on the brain, then if the brain gets bruised, it doesn't heal as well. The soft tissue heals perfectly fine. So basically, we remove this bone, right, at the base of the skull, so I don't have to lift the brain up and work through the corridor created by that to get to where the pituitary tumor is. If it's more off to one side, the sort of the one thing that I don't like about this approach is that your smell gland, right, your smell nerves are right in the middle here. These little holes are where the nerves for the smell olfactory bulb go through. So doing this approach, often I have to sacrifice at least one side to get back here. Sometimes I have to sacrifice both sides. So most of the patients, if I have to do an operation like this, then they'll lose their sense of smell. To avoid that, more when the tumor sort of draped over one side, not both sides, I do an operation from the side. So similarly, instead of making an opening in the middle, I make an opening in the side, right, and remove the eye socket on the side, also to get access to where the pituitary gland is without lifting up on the bone. So these are the type of bony cuts I would make. Remove the bone around the eye socket as well. So again, this patient had a similar, well, not this patient, this plastic skull has a similar sort of opening. So this window here I removed, right? And then I would remove this piece of bone. So not as big a piece of bone as I shown on that last skull, but this piece of bone will be removed, and I can sneak in with a microscope to get to the tumor, which is sitting right here. Through this corridor that I made by removing the bone. And the bones I'll put back in again at the end using little plates like this, or titanium plates.
And the latch?
Oh, the latch is just specific to this model. Okay. So this is, again, same thing. This is the picture from above where that orbital bone is removed. And I'd actually remove all this bone as well behind it. And I would remove all the bone around the vision nerve. And one of the reasons I would do that is because the tumor is underneath the vision nerve, right? So sometimes we need to manipulate the vision nerve a little bit. And if I didn't remove this bone around the vision nerve, the nerve is sort of anchored within that little hole, right? But if I remove all the bone around the vision nerve, I can actually have a little bit more space where the nerve can be moved around because the tumor sits underneath it. So this patient, right, had that type of procedure. This patient had a very rare complication. The procedure went very well. We removed a large amount of tumor and went home. But about 2 or 3 months later, she came back into hospital with a really bad headache and a sudden weakness on the left side. This is a CT scan. And on the CT scan, you can see what's white on CT scan is bone and also blood. Okay, and she's had a hemorrhage, okay, unfortunately. And when we looked at their blood vessels, okay, so this is an angiogram. So there's a little catheter that put in the groin, and you run some dye into the blood vessels, and you see this little bleb, which should not be there. And this is called a pseudoaneurysm. So basically, the artery is bled. Right? There's a hole in the wall of the artery, and there's some blood flow within a little sort of. It's not really even a bleb. It's a blood clot that's sitting on top of it. So the bleeding stopped, right? Because there's a blood clot sitting on top of it. But there's a little cavity within the blood clot where there's still blood swirling, okay? So this blood here is actually not within the blood vessel anymore. It's swirling inside the blood clot, okay? And this is a 3D angiogram that shows this. This is what the blood clot, the blood, the bleb, or not the bleb, the flow within the little blood clot. This is a bad problem. You can imagine all that's stopping the bleeding is this blood clot sitting on this hole in the blood vessel. And if you don't do anything, it'll bleed again, and maybe it won't stop next time. It's actually a really bad problem. And it's a bad problem because I'm not sure if you've heard of aneurysms. Aneurysms are little blebs in the blood vessels that patients are born with that can sometimes bleed. Aneurysms are actual blebs, right? They're little blebs in the wall, so you can actually repair them. There's an actual cavity, blood vessel wall cavity. Sometimes you can put coils in them to plug them up, or sometimes you can put little clips over the base of the aneurysm to stop the flow within the aneurysm. The problem with this is that there's no wall on this bleb. It's just a cavity within a blood clot. So there's no sort of clip you can put on. You put coils inside it, it just goes into the blood clot, and there's nothing for it to fill up. So when you have this problem, you actually have to sacrifice the vessel, right? So you have to put a little clip proximal to the injury and distal to the injury and sacrifice the vessel. Well, then what happens to all the blood in the brain that's fed by this blood vessel? Right? There's no blood flow to that part of the brain. You can have a stroke. So in this situation, what we sometimes have to do is use a different blood vessel. So this is the same patient, right? And these little clips, these are titanium, and there's two of them, one in front and one behind that little injury in the blood vessel, right? But this is a blood vessel you hadn't seen on the other pictures because it's a blood vessel that I put in there. So this is an artery from the arm, okay? And the proximal component, this part down here, goes into the carotid artery in the neck. And then this part down here goes into the blood vessel distal to where those clips were. And most likely, right, this injury or this problem occurred because I was trying very hard to dissect the tumor away from this main blood vessel. There may have been an injury or a minor injury to the wall that wasn't bleeding during surgery, but there was the weakness in the blood vessel that started to bleed afterwards and opened up. Could this happen through a transnodal procedure? Yeah, it can. It doesn't happen too often, fortunately. Sometimes we have to do, if it happens through a transnodal procedure, right? Sometimes we have to do an opening in the skull and take a blood vessel and bypass that whatever is injured as well. Doesn't happen very often, unfortunately. So anyways, so I have to show you guys, right, stuff that, can happen as well, and stuff that we can't always go into. Unfortunately, as I said, it's very, very rare. I've had that patient where I've had to do that, a bypass. I've had one patient where through a transnodal where we had to do a bypass after transnodal surgery. But usually those patients, there's usually some particular anatomy that makes them prone to that I would be able to detect and warn patients about before the fact. So that patient with a big tumor, those blood vessels were encased, right? Through a transnodal procedure, there's be some unusual anatomy as well that we'd be able to predict before we'd go into surgery, and those kind of things would be discussed. So this one is a relatively straightforward. It's sort of, it's less than an egg. It's a small, sort of round-shaped tumor, and this would be very good for a transnodal operation, right? Because the carotid arteries are to the side, and there's a big cavity, air cavity, sphenoid air sinus that you can use to access it. So this one we're showing the same skulls again, but working through the nostril. Again, it's a straight shot to where this is, and basically we make a few holes in the bones, and make a hole in the bone here to get access to the sella where the pituitary gland sits. So we follow the nasal septum down. These are turbinates, eye sockets, nasal cavity, and there's 2 layers of bone that we have to go through. If you go through this layer of bone, you get into the sphenoid air sinus, and then there's another layer of bone you have to go through to get to the pituitary gland.
So that can all have scar tissue then, because
Mhm.
I know this side is not the same as this anymore.
Yeah, it depends on how the operation was done and how much of the mucosa was removed and whatnot. We all try to not remove as much mucosa so things heal okay, but it depends. Yeah, sometimes you can have some scar tissue and things can become narrower. Usually, most patients actually, often the air passages become larger after surgery. Yeah. Yeah, craniotomy. Yeah. Yep. Yeah.
Covers our bone, or covers our brain, that's in between the brain and the bone, it's like the water usually part.
Yeah.
What happens to that?
Oh,
How do
we,
you fix it? How
oh,
does it go back to
oh,
normal? Is it cutting into it?
yeah. That's very straightforward. Actually, it's a fairly durable or thick membrane, right? And you can make an opening in it, and you can suture it back up. Yeah. Well, the membrane is a membrane.
It's like a spongy though.
No, it's separate. So there's a membrane, meaning it's like I don't know. It's like not quite like Saran wrap, but it's like a thin tissue that you can cut and you can suture back up, and then the fluid's underneath that. So the fluid. Well, it's not. It heals. Yeah, it's not self-sealing. You have to suture it closed. Yeah, but the fluid is inside that, and it's like a bag. You can open up the bag and you can suture it closed. The fluid is inside the bag, and the brain sort of floats inside. Have I lost you guys? You guys are okay? Yeah? Okay. Is this okay? Yeah? Okay. So I've talked a little bit about craniotomies. I'll talk a little about transfenoidals. So transfenoidals basically means going through the sphenoid sinus. That's the air cavity at the back of your nose that we work through. That's when you go through that first layer of bone, you're in the sphenoid sinus. But there's a whole bunch of variations on how you can do this through the nose. You can do it with a microscope, and that's what most people start out doing. I guess some of the younger surgeons probably haven't used a microscope for these procedures because more recently we've been using the endoscope. But if you do use the microscope is actually very good, and you can get very good visualization. You can use the microscope sublabially, meaning that it would work underneath the lip, and I'll try to show you a picture of that, versus working right through the nostril. Okay. You can use the endoscope. You can use the endoscope to do your opening and use the microscope to remove the tumor, or you can do the endoscope to do everything. And there's pros and cons to that. I'll try to explain. Doing okay with time? Yeah. You can use the endoscope to do everything through one nostril. You can use it do an opening through both nostrils. You can do extended approaches so that you can not just work in the pituitary gland or sella, but you can work more anterior or posterior to that. So microscopic sublabial. So let's be using a microscope. This picture shows, that's the nose, right? That's the teeth, obviously. You make an incision in your gums, and you lift the lips up. And this septum here, right, is the septum you see inside your nose. So where is it here? It's this one here, right? So it's an incision on your gums to lift the lips up, and you work this septum here, and you work back on the septum to get to the sphenoid bone, which is way at the back there. We started out doing it this way because we didn't want to go into the nasal cavity because we thought that the nasal cavity was dirty, right? We can't really clean it very well, before the operation. We're worried about infections. So we basically went up, because we can clean the gums really well, we had an incision up on top of the gums and dissected and peeled the skin off, peeled the skin off the septum, the middle part, the septum of the nose, so that you actually stayed out of the nasal cavity altogether. And you pushed the skin, made a hole, dissected the skin off the bone, and you made a cavity through the nasal sort of mucosa membrane.
How long ago did you start this thing?
This one, 20 years ago, we're doing this.
So
Yeah.
I would have had the choice, eh?
Excuse me?
I would have had the choice.
Maybe, I don't know. Yeah.
They don't give you a choice.
Well, let me explain that to you. Okay. Yeah. Well, anyways, so that's the sublabial approach. But after a while, we learned that we're doing this. So this is a picture here again, right? So you're working from below, and this is the mucosa on the nasal septum. And we just lift the mucosa off. We put these metal speculums in to hold them away, and we work through. And this is a picture from the top, right? Those are ears, and it's a slice through this way. So that this is where the sphenoid sinus, and that's where the pituitary gland is, and we work through this lower corridor, through your nostril, moving the skin to the side. But we learned doing this that sometimes we try very hard to stay out of the nose, so we end up making holes in the nasal mucosa and end up with big holes. And you get into the nasal cavity, and patients seem to be okay, and they didn't get infected. So surgeons started working just through the nose and didn't bother doing the dissection of the skin around it. We just went through the nose and made a big hole in the back, and that seemed to work perfectly fine. So this is sort of the metal speculum that we use, right? This is a picture from the side again, that's your teeth. We're working through here, and we're making a hole in the bone here, and this is where the pituitary gland is. And this is an X-ray we sometimes use to make sure we're going the right direction. So this is the same thing, except we're going through the nostril. So as I said, we tried very hard initially to stay out of the nose, but then we realized that maybe we don't need to do that. So surgeons started working through the nostril itself and elevating the mucosa off the septum inside the nose, and then putting the speculum in and removing the bone that way. And didn't worry too much that you're actually working through the nasal mucosa. It didn't seem to cause any problems with increased infections or anything like that. And then the endoscope came, and the endoscope's been around for a long time, actually. So the first endoscope was somewhere in 1800s. Early 1900s, surgeons were using laparoscopes to look inside the belly. They couldn't do very much, but they're using it to look inside the belly, looking inside the the gynecologic organs as well with little scopes, working through the chest, thoracoscopes. 1950s, you started getting fiber optics, right, which helped with the illumination. And with better screens and fiber optics, better scopes in the 80s, mid to late 90s, we started using the endoscope in neurosurgery. Okay, and the main sort of advantage that people talk about is this panoramic view. So you can see a little bit better to the side using an endoscope. It's like having a little hole that you're working through. If you're working through a little hole, right, if your eyeball is closer to it, you can see more to the side, as opposed to being further away and trying to work through a hole. So basically what the endoscope allowed you to do is put your eye there, so you have a little bit more wider view. The difficulty with endoscope is that it's 2D. You're working on a 2D screen, right? So you don't have the 3D sort of picture. And you can get around that and get used to the 2D by doing a number of things. But you can imagine if you're working around blood vessels and nerves and whatnot, it's quite useful to have 3D. And that's sort of the problem with the 2D endoscope, main problem. There are 3D scopes available, and surgeons use them. The problem with the 3D scopes is that you have to wear glasses, right? 3D glasses. And for me, it's glasses on top of glasses. If you're working for a couple hours, that can become a little more difficult or sore on your nose. And the 3D isn't quite normal. Like it's not the normal sort of normal not orientation. The feedback isn't the same. So it's like going to movies, right? Watching a 3D movie, and you can see things in 3D, but you know that the spatial resolution isn't quite right. And that's sort of the feeling you get when you're working with a 3D endoscope, and you start getting headaches after working for a few hours because of that. So I don't like using a 3D scope, and most surgeons don't like the 3D endoscopes. They're just not good enough. And it's an image on the screen, and I'll go over that when I show you pictures in a bit. But the image on the screen is okay. With HD TV and HD screen, it's not too bad, but it's not the same. If you have light hitting an object, going through a bunch of lenses and going and hitting your retina, it's much crisper or better image, regardless of the HD or the resolution or whatnot, compared to looking at a screen. It's just different. So this is just tries to describe that as well. So when we're working through a microscope, we're working through this sort of channel or corridor, right? And the light is out here, and you're shining a light in, and you're sort of looking in. Whereas with the endoscope, you have this more sort of wider view because your light source and your eye, what you see, is way down closer to the object. So again, when you're looking at the important structures, so this is just a diagram. This is the pituitary fossa, and that's the carotid arteries to the side, right? You have a little bit better view to the side, which is sometimes useful. So this is a picture of a microscopic pituitary tumor resection. And you can see the pictures that they've taken through the microscope where you're working through the nostril, and you put these metal sleeves in to hold the nasomucosa away, and you get a view inside the scope, and it's hard to see, and you can't see very much. And these pictures, you see that, and how can surgeons see what's going on? You can't, that doesn't look very, very good. And then you see a picture like this, right? So this is the endoscope, right? So you have this big sort of panoramic view. Instead of just seeing this here, right, would correspond to this, right? You can see things much better, huh? You can see the carotid artery to the sides. This is the bulge, right, from the carotid arteries. You're working through this big air cavity, and you can see structures very well. You can see instruments and whatnot. This looks really, really good. The problem is, right, I actually don't need to see that. I know where it is. If I can move my microscope a little bit and see it to the side, and once I see I know where it is, I don't actually need to see it all the time. So again, right, so looking through this, and this is the microscopic view. And when you go to meetings and people talk about endoscope, this is what they'll show you and say, well, the endoscope is so much better in terms of the visualization and whatnot. But it's a little bit of a fib. As I say, you actually don't need to see all that. And this is a microscope view, right? This is the metal sleeve around it, and you actually can see structures really quite well under the microscope. And you can see this, it's obviously on the screen, but you can see it in 3D, right? When you look on the screen, right? So when you see that, it's on a screen. This is exactly what the surgeon sees, right? It's a TV screen. The TV screen, you can have big screens, but not that big. And this, regardless of how big the screen is, it only probably fills up maybe about 20% of your visual field, right? Whereas if you're looking at the microscope is different. So that this is not what you see. You can't show people what you see under the microscope on a picture, because your eye is actually right on the objective on the microscope. So this picture, when I'm working, fills my entire visual field. My entire visual field is filled with just this picture in 3D, okay? As opposed to looking on a screen where I see this. So with respect to a microscope or endoscope, and people saying, well, you can see so much better with endoscope, that's not really quite true. You can see the sides a little better. People working, and the nurses can see a little bit better, but the surgeon himself may or may not be able to see as well. You certainly don't see it in 3D. And the 3D you could see it in with the 3D endoscopes and 3D screens isn't very good. So what I'm trying to say is that actually the microscope works really well too. And it's not a huge difference whether you're using a microscope or an endoscope, because there's pros and cons to each. So, if your surgeon's done 100 cases, with a microscope, it's probably better for him to do your case with a microscope and you not be the first 20 or 30 that he does with the endoscope. If your surgeon's only used an endoscope and that's all what he's used to, it's probably better for you to have your operation done using an endoscope. So usually you're never the first 30 because younger surgeons will always work with a senior one. So that never usually happens. They would have done 30 cases, most of my residents would have done 30 cases with me in their training, or more than that, they would have done 50 or more. Even when they start out in practice, usually there's another surgeon that's, if it's a conscientious young surgeon, right, they'll have another surgeon helping them. So it's rare that you would be the first case, without any help or any other supervision or any other, it's unlikely for you to be like a guinea pig or something like that. But those are all important questions. Those are questions that you just ask your surgeon, right?
Well, every time you go to a site, do you not, check with your surgeon, how many of these have you done?
Yeah.
And it just leads to the, well, where did they get the first one?
Yeah. Well, yeah. So if your surgeon's honest, they'll tell you, and they'll tell you that they'll be working with somebody else, or there'll be a reasonable explanation of how they've got their experience. And you're right. They have to start somewhere, but usually the things are set up so that it would be very unusual for a young surgeon right out of residency do their case by themselves, not have any backup. There'll always be someone that's more senior that can help. Yeah.
What if the student is in there
Yeah.
doing it with the supervisor
Mhm.
and he does something wrong? Then
Well, that can happen. That can happen. Sometimes that can happen. The job of the supervisor is try to prevent that the best he can. And in general, we're given the residents or the students are given parts of the procedure where bad things don't happen or bad things can't happen. And you start off by assisting, right? Perhaps holding on to the scope and not holding on to the instrument, right? That's making the cuts or whatnot. And then you may progress to holding on to the suction device to clear the blood away while the surgeon's working, right? So there's a gradation. Yeah, good questions though. There's something called a frameless stare taxi. It's like a GPS. So when we start these procedures, like you saw initially, there was an X-ray with a picture from the side with a metal instrument in the nose. So when we started doing this, we tried to make sure you're sort of in line with where you want to operate. When we started we're using X-rays. But more recently, we have this thing called the frameless stare taxi. There's a bunch of brand names of this as well. There's a Brain Lab. There's a Stealth, there's a bunch of things. It's like a GPS thing, and you sort of upload your patient's pictures into this computer, and this thing has little cameras in it. It's usually infrared, but it can be magnetic as well. And you can use it to track your instrument. So know where your instrument's at, so you know you're not right over the blood vessel as you're making a cut in it and make a mistake. Sometimes we clamp patient's head inside a little metal thing like this, or your head would be sitting in here like this, right, to hold your head really still, and during the procedure, and then we would clamp a structure like this onto the metal part, right, and this is a little antenna. It's with these little reflective balls, and these balls are seen by that camera, okay, and the computer is able to tell you where you're operating with relationship to all that. Does that make sense? There's also a little, all these little fine instruments that you can use, and you can clamp these little spheres on them so that you can use that to track where your instrument is while you're operating, right? So you know exactly where you're operating. And these are the kind of pictures you see on the screen while you're operating. So, we can use a little probe with one of these balls on it. Sometimes we have these balls. Sometimes it's like a magnetic thing, so it's a little chip that's hooked up with a little piece of wire onto the computer. There's a number of different ways you can do it. And you'd have these pictures, and if your tumor's there, you can see where you're operating, you can see where your vision nerves are and whatnot to try to avoid these structures. Having said that, if you go back to some of those pictures I was showing you, right, where the blood vessel is and carotid, the resolution or what you see on the pictures, because the pictures are on the preoperative scans, right? The pictures you see aren't quite enough detail, right? This is exactly what you see on the screen. You can't really see the bulges and things like that very well on the MRI scan pictures. You get a good idea, but your accuracy is probably only good to maybe, 2 or 3 millimeters at best. Right, and that you have to rely on your surgeon to be able to figure out, because 2 or 3 millimeters can be too much. You can get into the blood vessel and whatnot. And so although these things sort of help, it's not totally reliable. And depending on the frame and whatnot, you're screwing things into the head to hold things, but things can shift a little bit, right? If the clamp comes loose or something like that, you can imagine a few degrees of change, right, makes a huge difference in terms of your accuracy. It can be a problem. The way we register the patient's sort of contours into the computer, so we have the patient's head clamp, we have this little antenna coming out to the side. The facial features get registered into the camera by a few different ways. You can use laser, which shines laser on the face, and the camera picks it up, so that it correlates the facial features to the preoperative scans, and that's how it knows its relationship to the little antenna. Sometimes you can use a little probe. There's different technology. You can use a little probe and put the probe on defined places onto the patient's face, and the computer picks that up and correlates to the preoperative images to correlate everything. But none of them are perfectly 100% accurate, because if you can imagine, you're putting a probe on different areas so that the computer picks it up and picks up the facial contours. If your skin's a little thick and or thin, actually, if you put your probe on, your probe jiggles a little bit, which it can easily on your skin. You can imagine it can be easily off by a few millimeters. If you're lying down, and for some reason, I don't know, your skin is, I don't know, if you had gone out, before you have your operation, you gone out and had some drinks the night before or something, you're dehydrated, perhaps you're a little bit slimmer on your face, might be a little bit different from the preoperative scans. If you lie down, your skin might pull down a little bit. There's a number of ways that, although theoretically things should be accurate, often they're not. And you can tell when you're operating. If I see a piece of bone that I should be pointing at, I can actually see me pointing at a piece of bone in surgery, and it doesn't correlate to the imaging. It's off by a little bit, right? So although these are good tools, if your surgeon isn't experienced and knows what they're doing, if they rely too much on these machines, you can get into trouble. So this is a picture, one of my cases. So this is working through the nostril, right? This is an endoscope. This is the middle turbinate. So one of the little turbinates within the nose. This is the nasal septum. We're working through the right nostril. That's a sphenoid ostium. That's a natural hole that goes into the sphenoid air sinus. And we're lifting up the mucosa, right, over the nasal septum. And then we remove some of the bone at the back, and we can get into the sphenoid sinus. So this is the sphenoid sinus. And then this is the bulge from the sala. The carotid arteries will be to the side, right? And this is the bulge from the sala, and I'm making a little hole with the scissors to get into the pituitary gland. And this is the dura. This is the dura over the pituitary gland, right? And we're using some of these sort of ring curettes or fine instruments to get in and sort of remove the tumor. And what we use, we curette things out in general, and most of the time they come out with curettes. But you can imagine we pick pictures where there isn't very much blood on the lens, but if you get a little drop of blood on the lens, you can't see very well. So this is at the end, the tumor's been removed, and this is the diaphragma. That's the normal membrane that sits on top of the pituitary gland. If for some reason the tumor had made a hole through that diaphragma, you can see the brain fluid leaking out, which can be a problem as well, and it needs to be repaired. Okay. So, yeah. Yeah. Yes. Yeah. 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 Yes. No, successful surgery for acromegaly, right, is to have the hormones come down. Yeah. And that's the, no, you can't, because there can be a little lump of tumor, on the side that you can't see, or there can be a film of tumor within the normal pituitary gland. And these tumors come from the normal pituitary gland, come from the pituitary gland, right? So sometimes it's very difficult to differentiate what's normal and what's tumorous. I think in general, in patients who have functioning tumors, right, acromegaly and Cushing's, we tend to try to remove some of the normal tissue along with the tumor to try to get a better control. But some of the tumors, if they go off to one side or around the blood vessel or something like that, it makes the chance of cure quite a bit less. Depends on the anatomy, yeah.
So I've been hearing a lot about how a lot of patients are being put on medication
Yeah.
prior to the tumor coming out.
Yep.
To shrink the tumor.
Yep.
And I'm hearing success rate on actually getting the whole tumor and actually
Yeah.
not having acromegaly
Yep.
or being in remission
Yeah.
is actually a beneficial thing. Do you think?
Yes and no. I mean, there has been some papers done on that, right? But the actual so numbers actually aren't as good as they make it out. There's maybe 10 or 20% improvement, but the paper that people always quote, there's only like 30 patients or something like that. It's not, very.
In Canada or worldwide?
No, it's the particular paper that people quote to use that particular approach. Yeah, so in general, I think it's reasonable. We use it sometimes as well, but mainly dependent on what the wait list is. So if it looks like it's going to be a while before I can get the patient into surgery, then sometimes we do start suppression medications. I'm not sure, I have to look at things, but I'm not sure that's made much difference. Yeah. Yes.
If the tumor comes back, does that mean it wasn't all removed in the first place?
It was not, well, no, it was not all removed in the first place. So you can get, the majority of the tumor out, say 95% plus the tumor out. The hormones may come down to virtually normal, but if there are some cells left behind, they can start growing again, and eventually the hormones will go back up.
So that's what's happening.
Mm-hmm.
Will that tumor continue to get bigger?
Well, it depends on what treatment you're on, right? Well, if you're not on any treatment, it's likely at some point it's going to get bigger, yes. Yeah. Yeah.
Does the size of the tumor make a difference in how bad your acromegaly is?
No, it's actually the level of hormones. Sometimes you can have a small tumor and have very high hormones. I'm not exactly sure why. So some tumor cells are a little more active in producing the hormone. So I'm not sure there's a huge difference. In general, you're right. Bigger tumors, the hormones tend to be higher, but that's not always the case.
So after the surgery, if the hormones all go up,
Yeah.
this is what was happening with me.
Yep.
And then they tried everything.
Yes.
Nothing worked until some of it. But why would they go up? Is it just the disturbance of the pituitary gland?
Would the hormones go up after surgery? They usually don't. That's a little unusual. Yeah, yeah, the hormones go up after surgery? Yeah, I don't know, that's a little unusual. I think most of the patients, the hormones go down because the bulk of the tumor is decreased, right? So anyways, I have to talk about, I've gone through some of the complications, right? Blood vessel injury and whatnot, but I have to talk about complications in general when I talk about surgery. The main complication, as I say in the office, is that the operation may not help, right? So, if it's a non-functioning tumor not producing a hormone, if I can get 80% of the tumor out and get the bulk and pressure off the vision nerve, if it's a slow-growing tumor, that may or may not become a problem in your lifetime, right? And that can be a very successful operation. When it's acromegaly, though, when the cells are producing an abnormal hormone, if I can only get 80% of the tumor out, and there's some tumor around the corner or something like that, that really hasn't helped you in terms of hormone. And that's the difficult thing with this particular tumor. So there's a significant percentage of patients where the operation itself doesn't help. Having said that, we do think that taking the bulk of the tumor does help the situation by decreasing the growth hormone, so that it does make it easier for the medication to try to control things. Okay, so we do think it's beneficial, and we do think that if your tumor is very close to your vision nerve, there is some benefit to trying to get it away from your vision nerve. Optic nerve injury, the complications really relate to the structures around the tumor, and there's a small risk of bruising the vision nerve. It doesn't happen very often, but it's possible. All these structures around the tumor are at risk. One of the reasons we're doing surgery is to try to prevent the tumor from affecting your vision nerve, right? But the vision nerve does tend to be one of the closer things. And if we don't do anything and tumors continue to grow, that's what's going to happen anyways. But it is something that is at risk. Hormones, the other hormones. So by working on the pituitary gland, because the tumor comes from pituitary gland, your normal pituitary gland can get injured as well. The main hormone we worry about is the water balance hormone, usually temporary though. The other hormones are more long-term hormones, and sometimes, if they're affected, rarely, you need pills to supplement them. I talked a little bit about CSF leak. So if that membrane above the pituitary gland is injured by the tumor, or there's a hole when you take the tumor out, then that needs to be repaired, because the brain fluid can leak out through your nose, and that's not very good. Fluid can come out through your nose, the bacteria can go in as well. So there's a number of ways where you repair that, and sometimes, sometimes we use some fat to plug up the hole. Yeah, use some glue and stuff. Other nerves, I tried to point out some of the other nerves on the scans. It's quite unusual for us to affect those nerves unless the tumor's affecting those nerves before the surgery. Pretty rare to get double vision after surgery. We talked a little bit about blood vessel injury and having to do bypasses and stuff. And this is the last slide. In general, I think there are very good effective treatments, and in general, acromegaly patients do enjoy a full life and essentially normal lifespan with all the different treatments we have. Acromegaly patients have a little bit broader noses, and that actually makes an operation to the nose a little bit more easier because there's a little more space. As part of acromegaly, the soft tissue increases in thickness as well, and that makes repair and things, the mucosa in the back of the nose, a little more robust, and the things a little bit easier.
Where do they put the clip?
The clip.
Well, there's something that was there, because I've got on the outside, it looks like there was a clip on there holding.
Yeah, well, there's no clip. Sometimes surgeons make a little incision at the base of the nose to make the nasal passages a little bit bigger. Sometimes if the operation is very long, right, and they had the endoscope or the scope pushing up against your nostril, or if you had the microscopic approach and you had the speculum in your nose for a long time, sometimes that can cause some abrasions on your nose, but it usually isn't a clip per se.
It looks like there was a clip mark, and it's still
Yeah.
there, and that's since 1999.
It wasn't me.
No, it wasn't. But I think it was the assisting doctor that was mad because I didn't know.
No. In general, because they're functioning tumors, the tumors tend to be a little bit smaller, right? Patients present with hormone problems rather than mass problems. So The tumors are smaller, and there's usually less risk to vision because the tumors aren't pushing up against the vision nerves. Acromegaly patients in general, you may or may not think so, but in general, they tend to bounce back a little bit faster. They get out of hospital faster. Yeah, they tend to do a little bit better. You may not believe me, but in general, that's the case. In general, patients do very well, and yeah, and often they're very appreciative and very nice.
Nice way to end it.
Okay. Yes. It depends. You need an MRI scan to follow the tumor, right? But as I said, I use a CT. Sorry, you need an MRI scan to follow the tumor, but you need a CT scan to look at the bony anatomy. So for surgical planning, I always use a CT scan. Yes or no, it depends on the tumor. So larger tumors you can, sometimes you can see a shadow. But when you're operating, for me anyways, it's more important for me to see those little bony septations and stuff. If you get me to the right spot, right, then I can see under the scope, under the endoscope or microscope. Well, the risks to the surrounding structures are very similar, right? The surrounding structure is the same. It's the craniotomy is just a bigger procedure. Having said that, although we remove all these bones and stuff like that, patients actually do quite well. They might stay a day longer in hospital, but in general, patients do very well. I don't know, it might be, or it might be something like that. Growth hormone is like a stress hormone, right? So it may be that, yeah.
So what are the chances for a second operation?
Well, it depends on what the pictures look like, right? If it's something that's, sometimes, you know, the growth hormone goes back up, but we can't see anything that's obvious on the scan. There's nothing for us to target during surgery. Sometimes there's an obvious nubbin, right, that we can see on scans, and we say, well, that should be resectable, we should be able to find that, right? Then that's possible. It depends on what the pictures look like. If there's a nubbin of tumor on the other side of the carotid artery, right, then I'd say that's probably unlikely, probably not very safe for me to try to remove that.
And do you see any development on the technology side that would make it easier to sort of redo one that only partially succeeded previously?
Well, you know, I'm not sure what to say. There's lots of technology out there, and people are trying a whole bunch of things. You know, I'm not sure what to say. Some of it's promising, and some of it's not. You have to be a little bit careful about, you know, your interpretation of some of the things. And so, for example, you know, the frameless stereotaxy thing, the GPS thing I was talking about, it sounds great, right? But when you're actually using it, because of all those sort of minutiae that I was talking about, it's not as, you know, great as you might think. When you're working in a hospital, particularly in the US, right, you have to have all the bells and whistles. Because if a patient reads something on the internet and you don't have that, then they'll go to another hospital where the hospital has that. And it's in the U.S. it's a income generating thing, right? So in the U.S. every operation that's done makes the hospital and surgeons money, right? In Canada it's the other way around. In Canada the hospitals get a set budget, and you have to operate in that budget. So every operation costs the hospital money, okay? So in the U.S. there's a big sort of drive to have everything that's new and fancy. It's good, but it's not as you know. So we have, for example, we have a robot, right? And it's kind of neat, and we're in the paper and whatnot. Some surgeons use it. We didn't use it for neurosurgery, but you were using it for other things. But when you look at the results, the OR time takes longer, so anesthetic time is longer. It didn't really help the outcome when it was looked at objectively. And our robot that cost I don't know how many $1 million is sitting in a corner in VGH, and although we have one, we don't really use it. And you know, every center in the U.S. has a robot, interoperative robot, right? Big center in the U.S. Some places use it. Interoperative MRI scan sounds like a cool thing if you can do an MRI scan during surgery, and maybe there's an obvious nubbin, or you can go back and take it out. Having said that, the MRI scan, even the newest ones, takes a number of, probably adds an hour to each case. We're not sure is overall useful or not. The patient's under anesthetic for an extra hour. There's another, it may decrease the number of cases that can be done during the day in the same OR. Most surgeons don't like it because of that. The pictures are good, but they're never as good as the pictures you get on the regular MRI scan. We are one of the first centers in North America to have an intraoperative CT scan. We had one 20 years ago, before anyone else. And we're using it after surgeries like this to try to take pictures and whatnot, but it wasn't very practical. It took longer. The patient was on an anesthetic. The skin was open for a longer period of time. We were worried about infections with patients being moved, in and out of the scanner with the wound still open and whatnot. And in the end, the pictures are never as good as the regular scanner downstairs. So most of the time, if we're concerned, right, we would close and take the patient downstairs and do a scan. And if there's a problem, we'd bring the patient back up. So although we'll probably get an intraoperative MRI scan, right, it's not as useful as it's sort of made in websites and hospital sites and stuff like that.
You got everything where you need.
Yeah, exactly. Yeah. So it's funny things. If you go to an operating room in the U.S., they'll have this huge sort of lineup of different instruments, biting this way, biting that way, 45 degrees this way, that way, whatever. Not, that's great. Have all that, right? But do I actually need that? No. I actually just need one that bites one way, and I can turn my hand to get it to go the other directions, right? It's those kind of things, right? So it's yeah. Yeah.
So, we have MRIs done every year because we have to have MRIs done to see if the tumor's coming back.
Yeah.
And now that,
In general, though, right, the MRI scan changes won't happen unless your hormones go up. So in general, if your hormones are okay, we can still do the MRI scans, but they're probably not as important.
okay, so we don't necessarily
No.
every year.
No. Correct. Correct.
Staying at the same or going down.
Yes.
Okay, because there has been all over Facebook, website, huge concern about all the MRI dye that is now staying in our brain.
Ooh, okay. I don't know. I haven't. No, I haven't recognized that is a problem. The dye, from what I can see, isn't staying in your brain because it's, yeah, it disappears. It's not.
Come out of your system within 24 hours.
Yeah.
Finding through autopsies that actually the dye is staying in brain tissue.
Yeah, I'm not sure what to say. I actually haven't seen that. And when we do repeat scans, you always get a scan done with or without contrast, right? Or without the dye. And the one done without doesn't show any dye. Right? So if your dye is persistent, you would think that the scans done without the dye would show the dye, but that hasn't.
I'm asking, do you really need to have it added here?
Yeah, you don't. Yeah, it depends on what the hormones are. Am I doing them every year? I don't think so. Every 2 years, I tend to decrease them, or it depends.
Mine was every year for a little bit, but now it's kind of.
Yeah, it depends on what the hormones are like, and if we're sure that, if we're happy to the hormones. If the hormones are, staying stable or whatnot, you'll probably have the scans decreased. But it might be the endocrinologist doing that, I guess. I don't know. Yes.
Did I understand you to say that an MRI without contrast is telling you as much as you need?
Yes and no. And sometimes, well, what do you mean?
Well, somebody said they get their MRIs without contrast.
Yep.
They're even worse kind the MRIs that you never get
The IV? Yeah, it depends, right? So the scans with the dye always shows any scar tissue or tumor a little bit better. Having said that, if you had a few, right? And we can compare on the same sitting, the one without dye and the one with dye, and we can still think we can see it on the one without dye, then you may not need it. Yeah, yeah. I mean, if you complain enough about it, am I organizing your scans or somebody else? Oh, okay. If you complain enough about it, they'll probably stop the dye.
That's how they draw all my blood work, because they can't read my arms. Last time I had hot towels, they were here, they were here, they were everywhere. With the small needle, it hurts a little bit more than the easy needle.
Yeah, and it depends on, what the suspicion is like, right? If they're not suspicious that there's a problem, then, yeah. And it's really a change we look for. So even on a, yeah, yeah, even on a non-dye one, you can see sort of outline fairly well. It's just that it's more difficult to differentiate between tumor and normal gland and scar tissue without the dye. But if you had a few scans and things have been stable, at least you can see the outline fairly well without the dye as well. Yeah, yeah, yeah.
I was
Yes.
just wondering, I have been reading a lot about the surgeries.
Okay.
And mostly through the nose.
Mhm.
Some people are talking about having it packed. I never had mine packed. What's the difference between having your?
It depends on who's doing the surgery and what's being done. So it's really surgeon preference, and it depends on how far back the opening's made into the sphenoid air sinus and how much mucosa they're elevating. So some surgeons, particularly if they're doing it with a otolaryngologist, right, they're used to making a little bit bigger exposures and having a little bit larger flaps that tend to be floppy, and they want to put a pack in so that the nasal passages don't sort of scar together, and so that your nasal passages remain open.
So would that be more after, like, if you had 2 surgeries, or?
Perhaps, yeah, it depends on what things look like. Yeah, but yeah, it depends on surgeon preference. I don't use packing at all.
And one other question is when I first was diagnosed with this, I was told, because my tumor was very small,
Mm-hmm.
and my endocrinologist had a really hard time finding it. But I was told that your tumor for this could also be in other parts of your body. Are you aware of that? Because I had to have a full body MRI, and she was looking for it even on my liver or my lungs.
Yeah, that would be very, very rare.
Okay.
Yeah, it can happen, but that would be really rare.
No,
Yeah, and it's usually not the regular, straightforward acromegaly. It'd be something else. Sometimes you can see that in pathology. That's very unusual.
Well, you're just covering all bases, I think.
Yeah, I mean, other functioning tumors like Cushing's and stuff, other things can sometimes have tumors in other parts of the body causing similar hormone problems, but not acromegaly. And I think metastatic or acromegaly that spreads be very, very unlikely, very rare.
Speaking of the whole body MRIs, don't you think that it would be wise for people with acromegaly to have full body MRIs occasionally to see the difference? Because I can sit and tell a doctor, oh, this is feeling, that is feeling, but unless you have a visual of it,
Yeah.
from 1 year to, well, not every year, but every once in a while, how do you know if it's changing or if there's anything there?
What's
Or if it's
changing?
all in my head yet?
What's changing? What do you mean?
Well, okay, I'll give you for instance, my left leg is in really bad shape, but the doctors and everything keep almost saying, well, oh, it's either arthritis or this. There's a little touch of arthritis. Now, if I've got a little touch of arthritis, I'm sure it wouldn't feel the way my leg is feeling. Even before I had the arthritis, there was something that happened to it that it really causes a lot of pain. And now with the weakness of my muscles, it's getting even worse. But the doctors still don't know what it is. They keep saying, well, there's nothing there. They've taken x-rays, but they can't find anything there. But to me, if you had these full body MRIs, you could see an acromegaly's body, if it's changing, if it's getting bigger, if the tufts are moving, anything. Doesn't that make sense? It's not a very comfortable procedure, and it's an all-day thing.
Yeah.
I really hated it.
Well, I'd rather know what's in here than for them to say to me, well, it's just in your
Right.
head, or it's this or that.
Well, I'm not.
I wanna know for sure.
I'm not sure. I guess if it's mainly a particular part of your body, then it probably makes sense to scan that part. Yeah. Yeah. Oh yeah. Absolutely. Yeah. Yeah. Absolutely.
I think we're getting thrown out of a little bit of time. Does
Okay.
anyone have any sort of important question that she wants to raise before we say thank you to Dr. Akagami? Then thanks for coming and for the little presentation.
Thank you. Thank you very much. You didn't have to do that.